going to be talking about the human brain, obviously, and its structure and functions, and especially the nature-nurture debate. The question of to what extent the connections are laid down in early infancy or in the fetus, to what extent they are acquired as a result of the child interacting with the world. And I'm not going to take sides on this issue. Well, okay, the bottom line is that it is very plastic and dynamic. Human brain it's a cliche to say it's the most complexly organized form of matter in the known universe. And one way to gain appreciation of this complexity is to just look at numbers. Brain is made up of neurons, which is basic structural and functional units of the nervous system. There are something like 100 billion nerve cells in the average human brain. Each nerve cell makes something like 1,000 to 10,000 contacts with adjacent neurons. The points of contact are called synapses. Each synapse can be inhibitory or excitatory, can be on or off. And based on this, somebody has calculated that the number of possible brain states exceeds the number of elementary particles in the known universe. This gives you some idea of the complexity one is dealing with in studying the brain. To look at it differently, here is this lump of jelly, 1.5 kilograms, which you can hold in the palm of your hand inside your cranial cavity. And this lump of jelly can contemplate the vastness of interstellar space, vastness of the Milky Way. It can contemplate beauty, it can contemplate the nature of God, it can contemplate the meaning of infinity, it can even contemplate itself contemplating, what we call introspection or self-awareness. So how does all this come about from this lump of jelly? That's the question. So the way we approach this problem is to look at patients, or indeed people who are otherwise completely normal, who have sustained a tiny injury in a small part of the brain, or a genetic change in a small part of the brain, and look at changes in behavior in these patients, changes in their minds. Often what happens is not an across-the-board blunting of all their mental capacities, often a highly selective loss of one specific function, other functions being preserved intact. That gives you some confidence in saying that this function is mediated by that part of the brain. And I'm going to show you a few examples of this. You all heard of phantom limbs. A person loses an arm, continues to vividly feel the presence of that missing arm. And I'm going to talk about that in a minute. But much rarer, and few people have heard of this, is a disorder. In fact, I don't want to call it a disorder because it may be considered part of the spectrum of normal body image, where a person who has led an otherwise perfectly normal life in society, has held a job, has had a family, seems quite fine. At the age of 60 or 70, suddenly says, ever since childhood, I've had the urge to have my own arm amputated. This is called apotemnophilia or xenomelia. And you'll often take a felt pen and draw the line along the arm. It's often an irregular line along which the amputation, very precise line along which the amputation needs to be done. Now, why does this happen? And some of them, about a third of them, go on to get it amputated. It's not legal in the United States. They often go to Mexico or to Canada, I'm told. They actually get it amputated. It's a serious medical situation. Although the patient actually often feels much happier and relieved once the amputation is done. So what's going on in these people? The standard theory, believe it or not, is Freudian. One view is this person it's a cry for attention. He wants his arm removed as a cry for attention. This seems ludicrous to me. I mean, why not remove your nose or your ear? Why something as drastic as removing your arm? Pretty drastic procedure for just getting attention. The second theory is even more absurd. That is, they want the arm removed so that they have a huge big stump as a substitute phallic symbol. This is actually there in some of the old psychiatry textbooks. I'm not making it up. You can go Google it. So all of this seemed absurd to me, so we came up with a different notion. These are collaborators in my lab who are involved in this work. Postdoctoral fellow Eric Alschuler, many grad students. And some of you may have guessed this slide was made by Eric Alschuler. We're just telling you about apotemnophilia. So what's going on in this disorder? If you look at the brain, on the side of the brain is a vertical strip of cortex. There's a big furrow in the middle of the brain called the Rolandic sulcus or central sulcus. Behind that furrow, there's a vertical strip of cortex called the somatosensory cortex, where touch is represented. So on my right somatosensory cortex, the vertical strip, is a complete map of the left side of my body. Every point has a corresponding point in the brain. This map is called the sensory homunculus, somatosensory map. So we at first thought maybe this map, which is complete in most normal people, in all of us, maybe that map is missing, congenitally missing the arm in this chap. That's why there's a sense of alienation of the arm. The patient says the arm feels odd and I want it removed. So we went and mapped the brain, and we found that the map was completely normal. Okay, so we were, of course, disappointed. We thought we might find the answer to this. But then we looked further behind. There's a second region in the brain, just behind it, called the secondary somatosensory cortex. And that region represents joints, muscles, tendons, and all of that. Proprioception. When I close my eyes and do that, is what's called proprioception. That's represented in S2, secondary somatosensory cortex. That map is also normal. Again, we were disappointed. Then we went further back to the superior parietal lobule in the parietal lobe, especially in the right hemisphere. Superior parietal lobule in the right hemisphere represents your complete body image. If I close my eyes, I have a vivid sense of my different body parts moving through space and time. I open my eyes and there's confirmation, visual confirmation where my body is. There's vestibular sense when I shake my head. All of this information converges on the right superior parietal lobule to construct a vibrant, dynamic image of your internal image of your body, what we call body image, what Sir Henry Head and Lord Russell Brain, two actual neurologists, called the body image. When we went and looked there, we found that the representation of the arm was missing in that body image, congenitally, presumably. So what happens in these patients is sensory input comes in normally from the hand, goes to S1, they put the strip of cortex, touch it normally, all of that is normal, but it has nowhere to go to because once it gets to the body image center, there's a hole. Therefore, there's an acute discrepancy. Sensory information gets sent to the brain, but there's nothing for it to receive it in the body image center. This discrepancy creates an acute sense of alienation of the arm, abhorrence of the arm. That abhorrence or discrepancy gets sent to the amygdala and other insula and amygdala and other structures, and the brain then develops anxiety and he wants the arm removed. So given these odd connections in his brain, this is the only explanation that makes any sense, and we confirmed it using brain imaging. So here is an example of the kind of thing we do. We take a strange, odd medical dysfunction, or in this particular case, you don't want to call it dysfunction because, as I said, the patient doesn't seem to mind, so you don't want to even call him a patient, in a sense, because they're often very happy once the amputation is done. So, and then we say, we discard the Freudian explanation and come up with a precise neurological explanation in terms of the neural circuitry in the brain, and pin down, play Sherlock Holmes, and then pin down the real neural cause of this strange condition. Okay, now next question is, there are obviously zillions of connections, 100 billion neurons and all their connections, and how do you study these connections, and to what extent are these connections laid down by the genome in the fetus or in early infancy, and to what extent are they acquired as a result of the child interacting with the environment? Now we stumbled on this or approached this when I was a medical student years ago, looking at patients with phantom limbs. You all know what a phantom limb is. An arm or leg is removed, the patient continues to vividly feel the presence of that arm or leg. Now you can get a phantom with almost any part of the body. You can get phantom even of internal viscera. Somebody with a uterus removed, for example, hysterectomy, continues to vividly feel menstrual cramps at the appropriate time of the month. Extraordinary. In fact, one person asked me whether they still get phantom PMS. I haven't had the courage to ask, but now one serious clinical problem with phantom limbs is that very often the patient can move his phantom, right? Very often he'll say, I'm reaching out and grabbing a cup, I'm patting my brother on the shoulder, I'm attempting to shake hands with you, I'm reaching out to grab the phone, things of that nature. So it's a very vivid sense of movement. There is no arm, so where does this sense of movement come from? It turns out it comes from the front of the brain, from the frontal lobes. The motor commands are issued from the front of the brain. They go from the premotor to motor cortex, and the motor cortex then orchestrates a precise sequence of muscle movements in your hand, and you reach out and grab something. Now when you do that, there's also feedback from the muscles, and then there's a CC, a copy of that command, as an email, right? So there's a copy of that motor command sent to the parietal lobe, the right superior parietal lobule, which I told you about, informing the brain, informing the parietal lobe, the body image center, what the intended movement is, and continuously monitoring the movement. So continuously monitoring the motor command signals is a region in the right superior parietal lobule, and indeed partly the inferior parietal lobule in the right hemisphere. Now when the arm is removed, the commands continue to get sent and continue to get monitored in the right parietal, and that monitoring itself is experienced as phantom movements of the phantom arm. Is that clear? So in a normal person, the frontal lobe sends a message to the arm, motor commands to move. A copy of the command, a CC, is sent to the right parietal, which is informed of the movements of the arm and the intended movements. Even if you remove the arm, the commands continue to get sent to the right parietal, which continues to experience these phantom movements. So far, so good. Now, it turns out about a third of the patients this is not true. They say they cannot move their arm. Doctor, my arm is frozen like in a block of cement, in a block of ice. I try to move it, but it won't budge. In fact, it's excruciatingly painful. It's immobilized. I have a paralyzed phantom limb. Now, what does that mean? It sounds like an oxymoron. A paralyzed phantom limb. And it's in an awkward position. He'll position his normal hand like this, and my hand is actually going backwards and touching the wrist, anatomically impossible. The phantom hand is going backwards. It's excruciatingly painful. If only I could move it and straighten it, it might relieve the pain. And I've been trying for the last 10 years. And as a result of this, the patients often get very depressed, and rare occasions even go commit suicide because there's nothing they can do about the pain. So what we thought was maybe visual feedback was critical. Very often, many of these patients have had an actual paralysis of the arm. The arm was intact. It was not amputated. And every time the patient attempted to move the arm, there was excruciating pain. Move, pain, move, ow, pain, move, pain, move, pain. So the very attempt to move the paralyzed, painful arm, the copy of the command is sent to the parietal lobe, the copy is monitored, there's associated pain. The brain learns that any command is associated with pain, creating a form of learned pain and learned paralysis. Then when you amputate the arm, this learned paralysis and learned pain carry over into the phantom, so you get this oxymoronic state of a paralyzed, painful phantom arm, a non-existent arm. So I said, this is a sort of far-fetched theory, nobody's going to believe it, but how do you test it? So I said, what if you give him now visual feedback, again, restore the visual feedback, that the phantom is moving again in precise response to the command. Well, how do you do that? He doesn't have an arm. Am I going too fast, by the way? Okay. So you want to give him the visual illusion that his phantom is moving again in response to the command. How do you do that? So we said, let's do virtual reality, take a signal from the motor command center in the brain, feed it into a video system, and give the visual illusion that the phantom is obeying his command. So I called up my colleagues at Caltech, and they said, well, this is about 10, 15 years ago. They said, well, you can do it. It'll cost you $2 million. And it's pretty crummy because that's when VR just got started, virtual reality. So we said, to forget that, let's do it much cheaper. So we hit on the way of doing it for $2, using a mirror propped up inside a cardboard box. So you have a cardboard box with a mirror in the middle. Assume I'm the patient. My left arm is a phantom. I put my phantom left arm on the left side of the mirror. It's painfully clenched in an awkward position. I can't move it. Put the normal arm on the right side of the mirror, which is shiny. Look inside the mirror at the reflection of the normal arm. Position the normal arm to mimic the felt position of the phantom, as shown in this slide. So you're putting the phantom on the left side of the mirror, putting the normal hand on the right side of the mirror, mimicking the position and posture of the phantom with the right hand, looking at its reflection. What you've done is to resurrect the phantom visually. Now I tell him, send mirror symmetric commands to both hands, both to the phantom and to the normal hand. The chap says, well, I can't move my phantom, you know that. I said, yes, but pretend you are. Pretend you're opening and clenching the fist, conducting an orchestra. Do mirror symmetric movements with both the phantom and the real arm. Pretend you are. He said, okay, I'll do that. So the first time I remember, he started looking inside. He chuckled, he said, oh, I see my phantom. Of course, he knew it wasn't real, it was just a reflection. But I said, okay, now move both your arms, clench and unclench. And he did this. He said, oh my God, doctor, it's unbelievable. My phantom is moving for the first time. It not only looks like it's moving, it feels like it's moving for the first time in 10 years. And it feels absolutely delightful. Close your eyes, do it again. It refuses to budge. Open your eyes. Oh yes, my God, it's moving again, It's wonderful. So I thought, well, this is great. I got this guy to unlearn his learned paralysis. It shows the critical role played by visual feedback in sustaining the phantom. So I said, okay, take this box home. You can't keep on wandering around with the box. Take it home and play with it, repeatedly practice for an hour each day. And then maybe you can dispense with the box and start moving your phantom again, right? So he did this, and a week later, it's a long story which I won't go into given our time limits. He phones me up and he says, my God, I can now move my phantom fluidly, and it's moving and the pain gets relieved each time I move it. So that was the first time we saw this. Since then, it's been confirmed on large-scale clinical trials, especially by Tsao and his colleagues in New England Journal, published in New England Journal of Medicine. The work was done in Walter Reed in the United States. So there are 20 patients of whom, or 21 patients, of whom 8 had the mirror, 8 had covered mirrors, plexiglass, 8 had just visual imagery. And you put the mirror there, look at the reflection. The patients who had the mirror showed a dramatic decline in pain, as you can see in that bottom graph. The patients with the covered mirror or the imagination, pain actually increased in the 4 weeks. This is about 1 hour a day for 4 weeks, by the way, pretty short time. And then they were reversed. The control group placebo group was put on the mirror. Placebo group also dropped in pain. That's about as strong as evidence gets in clinical medicine. Now we said, what about other disorders besides phantom limbs? But before I complete my story on phantom limbs, there's another extraordinary observation we made on phantom limbs which I want to tell you about, which is what are called mirror neurons. So this was discovered by Giacomo Rizzolatti both in the frontal lobe and parietal lobe. I'll tell you about the ones called the sensory mirror neurons. These are neurons. Remember I showed you that vertical strip with a map of the body surface? So if somebody were to touch my left thumb, a particular point in that vertical strip will fire. In the pinky, another point will fire. My face, another point will fire. There's a map. That's been known for 50 years or more, 100 years in fact. But some of these neurons, about 10% of them, will fire if I simply watch you being touched. So we call them empathy neurons. It's as though the neuron is signaling to the brain, same thing is happening to this chap in the audience as would happen if I were to touch you. Therefore, experience his touch, experience empathy to his touch. Similarly, if somebody pokes me with a needle, anterior cingulate in my brain will fire cells. I simply watch somebody else being poked with a needle, the same neuron fires. This is called empathy for pain neurons. The neuron is saying the same thing is happening to that guy as would happen if you were poked with a needle, so please empathize with that guy. However, I don't literally feel the pain and say, ouch, and withdraw my hand when I watch you, however intense my empathy. Now, why is that? How does a neuron know the difference? That's because you signal from your own hand, pain receptors are sending a null signal up to the brain, saying, don't worry, you're not being pained, it's only that chap who's being pained. Empathize by all means, but don't actually shout and withdraw your hand. That would be silly. How do you test this? Well, if somebody were to amputate my arm, and I have a phantom, and I watch you being poked with a needle, suddenly this null signal is removed. I should actually feel the pain in my phantom. That's exactly what happens. We've done this in many patients. If you have phantom limbs have been known for over 100 years, 200 years. Nobody found this or even observed this. That a phantom limb patient watching another patient being touched, another normal person being touched on his arm, feels it in his phantom arm. So much so that one of our patients went home, whenever he had excruciating phantom pain in his arm, had his wife massage her own hand. He simply watched the massage, and his phantom massage was experienced in his hand and relieved the phantom pain. We've not done clinical trials on this, but are setting up to do it. So the mirror visual feedback has now been used for phantom pain, and it's used for complex region. It's been used for stroke, by the way. It turns out there's a large component of stroke paralysis, which is also learned paralysis of the kind you see in phantoms. And that learned component can be corrected with mirrors in stroke. So about 50-60% of stroke patients experience some recovery of hand function, arm function, grip strength with just using mirror visual feedback. And about 10% of them experience striking recovery, so it's well worth trying, given it's very non-invasive. There have been many clinical trials. You can just go Google mirror therapy with stroke. But what I want to tell you about before I conclude my lecture is an extraordinary disorder called reflex sympathetic dystrophy or complex regional pain syndrome. This is just clinical jargon. It means we don't know what the hell it is. Okay? So let's talk about complex regional pain syndrome. All of you know about if there's a tiny little fracture of a metacarpal bone, I say a hairline fracture, it can still be excruciatingly painful. Your hand gets immobilized, finger gets immobilized, hand gets immobilized as a measure to prevent further tissue injury from moving the hand, right? So there is pain, there is reflex immobilization or paralysis, quote unquote paralysis of the finger. Then there's swelling, there is redness, hyperemia, and changes in sweating, autonomic changes. Now that's well known. And after a week or 2 weeks or 3 weeks, the fracture heals, the swelling subsides, the pain subsides, and the finger can start moving again. This is a normal sequence of events in 97-98% of people. But in 3% of people, that's not what happens. The swelling, the pain persists with a vengeance. The swelling increases. The immobilization becomes paralyzed. The whole hand becomes involved, swollen, inflamed, red, painful, paralyzed. the entire arm becomes swollen, inflamed, paralyzed, and the bone starts atrophying, skin starts atrophying. This is called reflex sympathetic dystrophy or complex regional pain syndrome. And you're stuck with it for life or for years and years. There's no known cure that's effective. Why does this happen? We reason that what's going on is, in the initial stages of pain, every time the patient attempted to move the finger, the painful finger, there's a visual signal saying you're trying to move the finger, and there's pain signals going back and saying, ow, it's pain. So the motor command itself is linked in a Hebbian manner to the feedback pain. So move, pain, move, pain, move, pain. So the patient simply gives up, right? And it refuses to move the hand. Now, why you get atrophy, why you get swelling, why you get inflammation, nobody knows. But it's the most striking example. We were the first to draw attention to this. The most striking example of mind-body interaction that we know of, or body-mind interaction we know of. So we said, what if you unlearn the learned pain? How do you do that? Anybody want to guess? Mirrors, of course. It's always the answer. That shows you a dystrophic hand. So you go back to the mirror, put the dystrophic, painful hand on the left side of the mirror, the normal hand on the right side of the mirror, and then you move, try to move both hands. The dystrophic hand, of course, doesn't move. It's paralyzed. You move it slightly, try to move it. Move the normal hand vividly. And you get a vivid impression that the dystrophic, paralyzed hand is springing to life and is animated and moving for the first time in years, without any pain, because you're not actually moving it. So the brain is getting signals, visual signals, saying, you can move this painful, paralyzed arm without any pain, and you can move it. It's not paralyzed. So this tricks the brain into thinking that there is no pain. And with repeated practice, and sometimes on the table, the very first time the patient tries this with a mirror. This is shown by Candy McCabe and Patrick Wall and others after we had suggested it. They put a mirror there, and Bob Raphael is another person who studied this. The hand actually starts moving online, and the temperature changes with the thermometer online. You can't fake that. You can fake pain or loss of pain, but you can't fake temperature, changes in sweating. The swelling starts subsiding. And in a few weeks, everything, all the changes get reversed, and the patient's back to normal. And there's a large-scale clinical trial on that, on about 48 patients, 1/3 of them on the mirror. Again, patterns very similar. On the mirror, the pain drops to 1 or 2 from about 9 or 10. In fact, the patient is essentially pain-free. On the covered mirror, on imagination, there is no reduction in pain. And you put them on the mirror, again, the pain reduced. This is an extraordinary example of mind interacting with body. So, what's the punchline? This old model of neurology comes from artificial intelligence to some extent in the last 30, 40 years, is the notion that the brain is made up of a number of autonomous modules specialized for specific functions. Of course, this is partly true, but it's a caricature. Autonomous modules, it's what I call the serial hierarchical bucket brigade model of brain function. Okay? So these modules are arranged hierarchically. Each module performs its computation on the incoming sensory input, makes some aspect of the information explicit, sends it to the next module in the chain. That module then performs additional computation, sends it to the next module. There's not much interaction between them. They don't talk to each other. But you've seen this is not true. In fact, visual input from a mirror can alleviate pain in the pain centers, can make you feel like your hand is moving, affect the somatosensory cortex. We have seen that the neurons also interact not only with each other. The neurons are constantly changing in response to being immersed in the sensory environment. So in a sense, the neurons are in dynamic equilibrium with adjacent neurons, and in dynamic equilibrium with the external world, and with the sensory input from the skin, as shown by RSD. And it goes both ways. The arrows go both ways, from the skin to the brain and brain to the skin, right? And in dynamic equilibrium with other people through mirror neurons. So this shows how extraordinarily, so that you can start feeling somebody else's pain. Think of the extraordinary implication of that observation, that you remove your arm. And in fact, we have shown this even with anesthesia. You anesthetize the arm. If somebody anesthetizes my arm, and I look at you being hurt, look at you being poked, I feel the poke in my anesthetized arm. So I'm in a state of equilibrium with you, believe it or not. And the only thing separating your mind from my mind, your qualia from my qualia, is the bloody skin. If I remove my skin, I start experiencing your sensations. So I call these mirror neurons Gandhi neurons, or empathy neurons. Because the mainstay of many Eastern religious traditions is there's no fundamental distinction between your mind and other minds. This muddy vesture of decay simply is an external shell. You remove the shell, I start merging with other people. Speaking metaphorically, of course. So let me conclude with that. Thank you very much.